Okay, sorry we got cut off from that last video. So what I mentioned was measurement of ICP. The biggest thing that you want to prevent and monitor is for infection. And as I said, more than 5 days, the patient is at greater risk for becoming systemic infection. So make sure that you assess the site for erythema, edema, as well as any purulent drainage. So measurement of ICP evaluates changes with the patient condition. There's also inaccurate readings caused by, you guys can read through that. I'm not going to reiterate it. So measurements, it can control ICP by removing CSF via a ventricular catheter. So this can be intermittent or continuous drainage. So if intermittent drainage is ordered, open the ventriculostomy system at the indicated ICP and allow the CSF to drain for about 2 to 3 minutes. Then the stopcock is closed to return the ventriculostomy to a closed system. If continuous ICP drainage is ordered, carefully monitor the volume of CSF drained. That's essential. Keep in mind that normal CSF production is about 20 to 30 milliliters per hour, with a total CSF volume of about 150 mLs within the ventricles and the subarachnoid space. So there's also a Lycox catheter. This measures brain oxygenation and temperature. It's typically placed in white matter inside the brain. So these systems, they provide continuous monitoring of the pressure of oxygen in the brain tissue. The typical normal range is 20 to 40 millimeters of mercury. A lower than normal level is indicative of ischemia. Typically, these catheters can also measure brain temperature. A cooler brain temperature may produce better outcomes. There's also a jugular venous bulb catheter. This is placed into the internal jugular vein, and it measures jugular venous oxygen saturation. We talked about that a little bit in hemodynamic monitoring. Placement is verified by an X-ray. So this catheter, it provides, a measurement of jugular venous oxygen saturation, which indicates total venous brain tissue extraction of oxygen. So moving on, and also there you can see a photo as well of the Lycox catheter. So as you see under interprofessional care, treat the underlying cause, you see adequate oxygenation, what you expect, your normal levels, your PaO2, the PaCO2, and of course the patient may be intubated and mechanically ventilated. Surgery, a craniotomy, which is removal of part of the skull. This may be performed to reduce ICP and prevent herniation as well. So for drug therapy, mannitol, typically this is the mainstay in the control of elevated ICP, and it's an osmotic diuretic. It expands plasma volume and it decreases viscosity, sorry, my cat is just all of a sudden in the photo here. This is Parker. You can't really see him, but you might have seen a little of him. He's 17. He's pretty old. So which parameter should the nurse monitor to determine this medication's effectiveness? So the answer would be increased intracranial pressure. Plasma expansion, so this reduces hematocrit and blood viscosity, out of the way, thereby increasing cerebral blood flow and cerebral oxygen delivery. So with the osmotic effect, fluid moves from the tissues into the blood vessels. Therefore, the ICP is reduced by a decrease in total brain fluid content. So obviously you also need to monitor fluid and electrolyte status. Hypertonic saline, as it says on the PowerPoint, it moves water out of the cells and into the brain. So of course with that you'll want to monitor blood pressure as well as your serum sodium levels. So turning the page, so interprofessional care, corticosteroid therapy. This decreases cerebral edema. Vasogenic edema. So this surrounds many brain tumors and it actually contributes significantly to morbidity. So this edema, it results from disruption of the blood-brain barrier, allowing protein-rich fluid to accumulate into the extracellular space. Other things you want to do is concurrent antacids, H2 receptors, PPIs, counteracts the excess of gastric secretion that occurs with corticosteroids. So other drug therapy, anti-seizure medications. So seizures increase metabolic requirements and cerebral blood flow and volume, thus ICP. So anticonvulsants, you can give these to prophylactically prevent seizures. Antipyretics, temperature reduction decreases metabolism, cerebral blood flow, and thus IP. So you want to prevent temperature elevations. Also sedatives, these prevent shivering. Barbiturates, these can decrease cerebral metabolism, causing a decrease in ICP as well as a reduction in cerebral edema. So nutritional therapy, as you see, it says hypermetabolic and hypercatabolic state increase the need for glucose. And glucose provides energy to injured brain cells. With enteral or parental nutrition, early feeding following brain injury may improve outcomes. So nutritional replacement should begin within 3 days after injury to reach full nutritional replacement within 7 days after the injury. So you want to keep the patient normovolemic. So typically your IV fluids that are preferred is sodium chloride, and that's preferred over D5 and W or half normal saline. So if 5% dextrose and water or half sodium chloride is used, serum osmolarity decreases and an increase in cerebral edema may occur. So nursing assessment, obviously you want to look at your subjective data, the level of consciousness, the Glasgow Coma Scale, and again, the highest score is about 15 for a fully alert person, and the lowest possible score is 3. A Glasgow Coma Scale of less than or equal to 8 is generally indicative of a coma. So this patient, you would expect them to be on a mechanical ventilation. Other things you want to look at are the patient opening the eyes, verbal and motor response as well. So if you are checking pupillary size and response, so if you're looking at the size of the pupils here, again, you need to look for, assess the size, the shape, the movement, and the activity. So if the oculomotor nerve or cranial nerve 3 is compressed, the pupil on the affected side is also called the ipsilateral side, and that becomes larger until it fully dilates. So if ICP continues to increase, both pupils will dilate. So always make sure that you're testing the patient's pupillary reaction with a pen light. As you know, the normal reaction, it's brisk when light is shown directly into the eye. Also, you need to note a consensual response, and that's a slight constriction in the opposite pupil at the same time. A sluggish reaction can indicate early pressure on cranial nerve 3. With a fixed pupil response to light, stimulus usually indicates increased ICP. However, it's important to note that there are other causes of a fixed pupil. So these can include direct injury to cranial nerve 3. Maybe the patient's had previous eye surgery. Maybe they've been administered atropine or use of other mydriatic eye drops. So with nurse assessment with corneal reflex, this gives information about functioning of cranial nerves 5 and 7. If this reflex is absent, initiate routine eye care to prevent a corneal abrasion. With an oculocephalic reflex, this is also known as doll's eye reflex. So with this, you turn the patient's head briskly to the left or the right while holding the eyelids open. So a normal response is movement of the eyes across the midline in the direction opposite that of turning. So next, you want to quickly flex and then extend the neck. Eye movement should be opposite to the direction of head movement. Up when the neck is flexed and down when it's extended. Abnormal responses can help locate the intracranial lesion. So this test should not be attempted if the patient does have a cervical spine injury, something you might want to think about. Other things that you look at, obviously, patient is checking their grips, as well as their grips against upper and lower resistance. Turning to abnormal respiratory patterns of a coma, you guys can go read through those different patterns. One that you'll be certainly familiar, you'll see in your career, is Cheyne-Stokes. And typically that's when a patient, they have periods of hyperventilation and then they have apnea. And the apnea can last up to 20 seconds, especially in your patients that are dying. I'm going to skip over nursing diagnosis. With planning, obviously you want to see your ICP return to normal. Acute care, so with respiratory function, you obviously want to maintain a patent airway. As level of consciousness decreases, the patient is at an increased risk for airway obstruction. That could be due to the tongue dropping back, and that occludes the airway. You need to make sure that you have the bed elevated 30 degrees. So the patient with increased ICP should be maintained in the head up position, and that will actually help to reduce ICP. As for suctioning needs, you only suction the patient when it's needed, not on schedule. And that's because you're decreasing the PaO2, and so that's going to increase intracranial pressure. And when you do suction the patient, they're on the ventilator, make sure you oxygenate them with 100% oxygen. Abdominal distension, that can interfere with respiratory function, so you may need to insert an NG tube as well. Excuse me. So with pain and anxiety management, opioids, morphine sulfate, fentanyl, these are rapid onset analgesics with minimal effect on cerebral blood flow. Diprivan, I'm sure you guys have seen this used in the ICU. It's used in management of anxiety, agitation as well. It has a rapid onset as well as a short half-life. Precedex, this is an alpha-2 adrenergic agonist. It's used for continuous IV sedation of the intubated and mechanically ventilated patient in the ICU setting, typically up to 24 hours. When continuous IV sedatives, one thing you need to be aware of is the side effect of hypotension. Neuromuscular blocking agents, Bezalate. These are useful for achieving complete ventilator control. Benzodiazepines, you're probably most familiar with these. These are usually avoided in management of the patient with increased intracranial pressure because of the hypotensive effect. Plus, they also have a longer half-life unless they're used as an adjunct to neuromuscular blocking agents. So acute care fluid electrolyte balance, I mentioned this. Monitor your electrolytes, monitor for diabetes insipidus or syndrome of inappropriate ADH. So with diabetes insipidus, it's caused by a decrease in ADH, and if you recall, it results in an increased urinary output as well as hypernatremia. So the usual treatment of diabetes insipidus is fluid replacement as well as vasopressin. If it's not treated, severe dehydration will occur with syndrome of inappropriate ADH. It's caused by excess secretion of ADH. So with syndrome of inappropriate ADH, you have dilutional hyponatremia. So what you would expect to see is a decreased urinary output, and again, dilutional hyponatremia. So this can result in cerebral edema, changes in level of consciousness, as well as seizures and coma. So obviously you want to monitor and increase and minimize increased ICP. So the Valsalva maneuver, coughing, sneezing, suctioning, as well as hypoxemia, that can increase ICP. So you need to be thinking about those factors. Other things, we mentioned head to bed elevated, prevent extreme neck flexion, turn slowly, avoid cough, straining, Valsalva, and also avoiding hip flexion. So I'm going to skip over the next slide and over expected outcomes. There are a few audience response questions. So anyway, the quiz is planned for not this Monday, but the following Monday. So I would make sure that you look at your bonus questions. And if you don't get full credit for that, make sure you find out the correct answers. I think there might be like 24 questions on the quiz. One is worth double. It's 8 points. It is a select all that apply. In the meantime, reach out to me if you have any questions. Thanks, guys. Bye.